Welcome back to the deep dive. Our mission today, well, it's to tackle a really big topic, the complex world of rheumatic disorders. We want to give you a clear roadmap.
It's a huge area, definitely. You hear rheumatic disorders, and it covers, what, over 100 different conditions?
Exactly. And they affect the musculoskeletal system, but also way beyond that sometimes.
That's right. They range from, fairly localized issues to these really complex, chronic, systemic autoimmune diseases.
The scale is pretty staggering, too.
Oh, absolutely. Think about osteoarthritis, OA. Over 30 million Americans have it. It's the leading cause of disability.
Wow.
Then you've got rheumatoid arthritis, RA, about 1.5 million. And it's not just adults. Around 300,000 kids have juvenile arthritis.
Yeah, the symptoms can really overlap, which I think is where a lot of the confusion comes in. But understanding what's driving the condition, the actual pathology, that seems to be the key to telling them apart.
That's the framework we need. It's not just about the symptoms, it's about the why.
So our goal today is to sort these into, let's say, 4 main pathological buckets: autoimmune, axial inflammatory, degenerative, and metabolic.
Knowing those categories makes a huge difference.
Okay, let's unpack this. Let's dive in with maybe the most dramatic group first. The systemic autoimmune rheumatic diseases, starting with rheumatoid arthritis, RA.
Right, RA. It's a systemic inflammatory disease. Affects maybe 1% to 2% of the population.
And it hits women more often.
Yeah, about 3 times more frequently than men. And you see it more as people get older.
We still don't know the exact cause, do we?
Not definitively.
Yeah.
But the evidence really points towards a mix of genetic predispositions, specifically that HLA-DRB1 locus you hear about.
Okay.
And then some kind of trigger, maybe a microbial agent, something external that kicks off a T-cell mediated attack on the joints.
So that HLA-DRB1 link, that tells us it's fundamentally an immune system issue, a T-cell response gone wrong.
Precisely. And immunologically, there's a key marker, the rheumatoid factor, or RF.
Yeah.
About 70 to 80% of people with the RA test positive for it.
Seropositive, right. And RF is an antibody that attacks our own antibodies.
Exactly. It's usually an IgM antibody reacting with the patient's own IgG, forming these immune complexes.
And those complexes are the troublemakers. They lodge in the joints, attract inflammatory cells,
which then dump out destructive enzymes, those lysosomal enzymes, and start chewing away at the cartilage.
But wait, if only 70–80% have RF, what about the other 20–30%? Does that make diagnosis tricky?
Oh, absolutely. That's seronegative RA. It's why doctors also look for anti-CCP antibodies. They tend to be more specific for RA, although not everyone has those either. But regardless of those blood tests, the really unique pathological hallmark, the thing that defines RA's destruction, is the pannus.
Okay, tell us about pannus, because this seems like a really critical differentiator.
It really is. Imagine the synovium, the lining of the joint, transforming. It becomes this thick, abnormal vascular granulation tissue that's the pannus.
And it grows.
It grows, yeah.
Yeah.
It creeps across the surface of the articular cartilage like an invasive weed. And crucially, as it grows, it physically blocks the cartilage from getting nutrients from the synovial fluid.
So the cartilage is getting attacked by enzymes and it's being starved.
Exactly. Double whammy.
Yeah.
Eventually, the cartilage is destroyed, the bone underneath gets eroded, and ultimately you can get ankylosis, the joint bones fuse together completely.
Clinically, you said it's symmetric and polyarticular.
Yes. Multiple joints involved, usually on both sides of the body, both wrists, both knees, for instance.
And we see characteristic changes, especially in the hands.
Definitely. The tendons can slip out of place, causing the fingers to drift towards the pinky side. That's an ulnar deviation.
Okay.
Then you have those classic finger deformities. Picture this. The swan neck deformity is when the middle joint of the finger, the PIP joint, hyperextends, goes way back, and the fingertip joint, the DIP, flexes down. It looks a bit like a swan's neck. The opposite is the boutonnière deformity, like a buttonhole. The middle PIP joint is stuck in flexion, bent inwards, and the DIP joint at the tip hyperextends.
And RA isn't just joints, right? It's systemic.
Correct. You can get rheumatoid nodules, these firm lumps under the skin, often over pressure points like the elbows, and in more severe cases, vasculitis, inflammation of blood vessels, which can be quite dangerous.
Okay, that's RA. Now let's shift to the other big autoimmune player, Systemic Lupus Erythematosus, SLE.
SLE. If RA is mainly about joint destruction via pannus, SLE is, well, it's about immune complexes causing chaos everywhere. That's why it gets called the great imitator.
It can mimic so many other diseases.
Exactly. It can affect virtually any organ system.
Like RA, it's more common in women.
Much more common, yeah. About 85% of cases are in females, and certain racial groups African Americans, Hispanics, Asians have a higher prevalence.
And the core problem here is B cells going wild.
Pretty much. You get this B-cell hyperreactivity churning out loads of autoantibodies, especially ANA, anti-nuclear antibodies, anti-DNA antibodies, anti-ESM antibodies.
And these form immune complexes too.
They do. But unlike RA, where they mainly target the joints initially, in SLE, these complexes deposit in tissues all over the body, skin, kidneys, lungs, brain, blood vessels, triggering inflammation and damage wherever they land.
Are there known triggers?
There's a definite genetic component, like HLA-DR and DQ links. Hormones clearly play a role, given the female predominance. And then environmental factors. UV light exposure is a big one. Sunlight can absolutely trigger flares.
Clinically, joint pain is common in SLE too, right?
Very common. Around 90% of patients report arthralgias or arthritis. But here's a key difference from RA. The arthritis in SLE is usually non-erosive. It hurts, it swells, but it typically doesn't destroy the joint structure like RA does.
Okay, non-erosive. What about other classic signs?
The skin is a major target. The most classic acute sign is that mallow rash, sometimes called the butterfly rash, redness across the cheeks and the bridge of the nose. Looks like a butterfly.
But the really serious stuff is when it hits major organs.
That's where SLE can be life-threatening. The kidneys are a major concern. Glomerulonephritis, inflammation of the kidney filters, happens in almost half of patients.
And some types are worse than others.
Yes. The diffuse proliferative type is generally the most severe and carries the worst prognosis. It can lead to kidney failure.
Wow.
We also worry about the lungs, pleural effusions, inflammation of the lining, and the central nervous system, things like seizures, psychosis, strokes, often linked to vasculitis affecting small brain vessels.
So that distinction is critical. RA is primarily erosive joint destruction via pannus, while SLE is widespread non-erosive inflammation from immune complex deposition.
That's a great way to summarize the core difference in this first bucket.
Okay, let's move to our second pathological category, the Seronegative Spondyloarthropathies, or SPA.
Right. We call them seronegative because, unlike most RA patients, they lack rheumatoid factor.
Okay, no RF. And they mainly affect the spine.
Primarily, yes. They target the axial skeleton. And the inflammation starts differently, too. It's not usually in the synovium initially, but at the entheses.
Entheses. Remind me what those are.
That's where tendons and ligaments attach directly to bone. So in SPA, you get enthesitis, inflammation right at those insertion points.
And the hallmark for the whole group is?
Inflammation of the sacroiliac joints, where the spine meets the pelvis. Sacroilitis, that's key.
And there's a genetic link here, too.
A very strong one, though not universal. The HLA-B27 antigen. Many, but not all, people with SPA have this genetic marker.
So let's talk about the main example, Ankylosing Spondylitis. AS. What's happening there?
AS is basically chronic inflammation attacking the vertebral column. It starts with that enthesitis inflammatory erosion at the ligament attachments on the vertebrae.
Which leads to?
Destruction, and then the body tries to heal by forming new bone. Over time, this abnormal bone formation bridges the gaps between vertebrae, leading eventually to ankylosis, complete fusion.
Fusion of the spine. What does that look like?
On an X-ray, it's pretty dramatic. The vertebrae lose their normal concave shape and become squared off. Eventually, these bony bridges can fuse the entire spine into a rigid column. It's often called a bamboo spine.
Wow. And that causes stiffness, loss of mobility.
Yes, and often a loss of the normal inward curve in the lower back, the lumbar lordosis. Patients can become quite stooped.
What are the main symptoms someone would notice early on?
It's often lower back pain, but here's the interesting thing. It usually feels worse with rest or inactivity and better with movement or exercise.
Opposite of mechanical back pain.
Exactly. And prolonged morning stiffness is very common. They might also get extraskeletal problems like acute anterior uveitis, which is painful inflammation in the front part of the eye.
Are there other conditions in this PA group?
Yes. Briefly, there are reactive arthropathies. This is where you get sterile joint inflammation triggered by an infection elsewhere in the body, like the gut or urinary tract. Reiter syndrome is an older name for one type.
Okay.
And then there's psoriatic arthritis, which develops in maybe 7% or so of people who have the skin condition psoriasis. It can present in several different ways, affecting different joints.
Got it. So we've covered autoimmune, RA, SLE, and axial inflammatory, CESPA. Now, bucket number 3, the really common one, osteoarthritis syndrome.
Yes, OA. This is our degenerative category. It's the most common type of arthritis by far.
And this is more about wear and tear, right? Though there's some inflammation.
Exactly. The primary driver is mechanical breakdown and degeneration of the cartilage. but the damage itself does trigger a secondary low-grade inflammation.
What are the big risk factors? Age is one, obviously.
Age is huge,
Yeah.
but also genetics play a role in primary OA, and then secondary OA can result from things like previous joint injury or metabolic diseases, and a major one is obesity.
Especially for knees.
Definitely for knees. The extra weight puts direct mechanical stress on the joint. But there's also evidence that metabolic factors related to obesity might negatively affect the cartilage itself.
So walk us through the actual breakdown process in the cartilage. What's happening at the tissue level?
Okay, so healthy cartilage is smooth, resilient. It's made of chondrocytes, the cartilage cells embedded in a matrix rich in collagen, and these molecules called proteoglycans, which hold a lot of water. Think of them as shock absorbers.
Right.
In OA, this matrix starts to lose its integrity. Early on, paradoxically, the water content might increase, but the crucial proteoglycans are lost. This weakens the collagen network.
So it loses its cushion and strength.
Precisely. The surface isn't smooth anymore. It develops tiny cracks, fissures, starts to fray.
Huh.
As it wears down further, you get complete erosion, exposing the underlying bone.
Ouch. And what happens to that exposed bone?
The subchondral bone, the bone just beneath the cartilage, reacts to the stress. It thickens, becomes dense, that's called sclerosis, and where the bones rub directly against each other, the surface can become polished and smooth, almost like ivory. We call that ebernated bone.
And those bone spurs?
Right, osteophytes. Those are bony outgrowths that form at the margins of the joint, sort of the body's attempt to stabilize the damaged joint, but they can cause pain and limit motion themselves.
Clinically, how does OA pain differ from RA pain? This seems vital.
Absolutely crucial distinction. OA pain is typically localized to the affected joint or joints, and the pattern is key. It worsens with activity or weight bearing, and it's relieved by rest.
So using the joint makes it hurt more.
Yes. Whereas in inflammatory arthritis like RA, stiffness after rest, especially morning stiffness, is often more prominent, and sometimes movement helps initially. Also with OA, you might feel or hear grinding or crepitus in the joint.
And the joint swelling is different too.
Very different. In OA, particularly in the hands, the enlargement is hard and bony. Think of Heberden's nodes, which are those bony bumps at the DIP joints, the ones closest to the fingertip.
Okay.
And Bouchard's nodes are similar bony bumps at the PIP joints, the middle knuckles. Compare that to the softer, often warmer, boggy, or spongy swelling you might feel in an actively inflamed RA joint. It's a night and day difference in texture.
Hard nodes in OA, soft swelling in OA. That's a great takeaway. Okay, final bucket. Metabolic disorders. And the classic example is gout.
Right, gout. This is all about metabolism, specifically purine metabolism. Uric acid is the final breakdown product of purines, which come from our diet and cell turnover.
And in gout, there's too much uric acid.
Exactly. You get hyperuricemia, high levels of uric acid in the blood. This happens either because the body's producing too much uric acid or, more commonly, the kidneys aren't getting rid of enough of it.
And that excess uric acid forms crystals.
Yes, sharp, needle-like monosodium urate crystals. And these crystals like to precipitate out of the blood and deposit in tissues, especially joints.
Why the big toe so often? That classic podagra.
Temperature seems to be a big factor.
Right.
Uric acid is less soluble in cooler temperatures. Peripheral joints, like the feet and toes, are generally cooler than the core body temperature, making them prime spots for crystals to form.
And when they form, it causes intense pain.
Excruciating pain. It's an acute inflammatory response. White blood cells, leukocytes, rush in and try to engulf the crystals. But the sharp crystals damage the cells, causing them to rupture and release inflammatory mediators and those destructive enzymes again. It triggers a massive, painful attack.
What happens if gout isn't managed over the long term?
Chronically, after maybe 10 years or more of recurrent attacks, these crystal deposits can accumulate and form large, hard nodules called tophi.
Tophi, where do those form?
You can find them in and around joints, in cartilage, like the ear, in tendons, and even under the skin. They can cause significant joint damage and deformity over time. It's also important to know gout is often linked with other issues like cardiovascular disease and metabolic syndrome.
How is it diagnosed for sure? Is high uric acid enough?
High uric acid supports the idea, but lots of people have hyperuricemia without ever getting gout. The definitive diagnosis comes from actually seeing those monosodium urate crystals under a microscope in fluid drawn from an affected joint, synovial fluid, or from a tophus.
Got it. Okay, just quickly, let's touch on the age extremes. Rheumatic diseases in kids.
Right, Juvenile Idiopathic Arthritis, JIA. It's really an umbrella term for several types of chronic arthritis starting before age 16. Systemic JIA is one type with high fevers and rash.
What's unique about arthritis in growing children?
The inflammation, the chronic synovitis, can actually interfere with bone growth near the joints. It might stunt growth at the epiphyseal plates or sometimes overstimulate it, leading to limb length discrepancies. That's unique to kids.
And juvenile SLE?
Often present similarly to adult SLE, but kids might have even more frequent and severe renal involvement, more kidney problems than adults typically do at onset.
And then at the other end, older adults. OA is king, obviously.
By far. And RA and gout prevalence also increase with age. But there's another condition we see almost exclusively in people over 50, Polymyalgia Rheumatica, or PR.
PR, what defines that?
It's characterized by aching and really quite severe morning stiffness, mainly in the shoulder and pelvic girdle areas, neck, shoulders, hips, difficulty getting dressed, raising arms, that kind of thing.
How is it diagnosed?
There's no single definitive test, but diagnosis is strongly supported by the clinical picture, age over 50, elevated inflammatory markers like ESR, erythrocyte sedimentation rate, and crucially, a dramatic, rapid response to low doses of corticosteroids, like prednisone.
That quick response to steroids is key.
It's almost diagnostic in itself sometimes. If someone with suspected PR doesn't get significantly better very quickly on low-dose prednisone, you'd really question the diagnosis.
And there's a serious potential connection here.
Yes, this is critical. PR sometimes occurs alongside, or can be the first sign of, giant cell arteritis, also known as temporal arteritis,
which is
a systemic vasculitis, inflammation of large and medium arteries, particularly branches of the carotid artery, like the temporal artery in the scalp. The major danger with giant cell arteritis is that it can affect the arteries supplying the eye, potentially causing sudden, irreversible blindness.
So identifying PR is urgent because it might signal this risk.
Absolutely. If giant cell arteritis is suspected, you need prompt diagnosis, often a temporal artery biopsy, and immediate treatment with high-dose prednisone to prevent blindness. The low dose used for PR alone isn't enough.
Okay, that's a really important clinical link. So let's try to tie this all together.
If we connect this back to the bigger picture, those 4 buckets are really helpful. You've got the autoimmune destruction pathway driven by immune complexes and specific cellular attacks, like in RA and SLE.
Right.
Then you have the enthesitis pathway, inflammation at tendon ligament insertions, primarily affecting the spine, leading to fusion and STA.
Bucket 2.
Bucket 3 is the degenerative wear and tear pathway of OA, with cartilage breakdown and bony overgrowth, osteophytes.
Driven by mechanics and aging, mostly.
And finally, bucket 4, the metabolic error pathway, like in gout, where crystal deposition triggers intense inflammation. Understanding which fundamental process is at play is really the key.
So for you, the learner, focusing on the pathogenesis, the underlying mechanism, is how you cut through the confusion. It's how you tell that soft, warm, symmetric RA joint apart from the hard, bony, use-related pain of an OA joint, or the non-erosive pattern in SLE.
Exactly. Which leads to maybe a final thought, especially thinking about younger patients. We mentioned that some spondyloarthropathies can start in childhood or adolescence, sometimes just with peripheral joint pain, looking a lot like JIA initially. But we know SPA can silently progress in the spine for years before x-rays show damage, potentially leading to irreversible fusion. So when you have a young person with joint pain, maybe some suggestive symptoms, but normal x-rays, how critical is it to get that molecular data early, like HLA-B27 typing or other markers to potentially head off decades of damage? What stands out to you there?
That's a really important question to ponder. Thank you for joining us for this deep dive into the complex world of rheumatic disorders. We'll catch you next time.